Welcome to Pomegranate Case Report for the Royal Australasian College of Physicians. I'm Mick Kabat-Zini, but if you haven't listened before, these case report interviews have been developed by Associate Professor Stephen Bacchi. He's a neurologist in Adelaide, so apologies if brains have features frequently in recent and forthcoming episodes. We're always keen to hear suggestions from the whole range of listeners, so feel free to send an email to podcast@racp.edu.au. Today's case report is actually the first one which was recorded. Call it the unreleased pilot if you want. Dr. Bacchi's intent with these is to model how case presentations should be queried. Today's story takes place in August 2021. A 27-year-old male wakes up with weakness in the left arm and left leg and gets himself admitted at Royal Adelaide Hospital. Shockingly, for an otherwise well young man with no significant medical history, a right middle cerebral artery acute ischemic stroke is identified by CT angiogram. And a mediastinal mass is discovered on review, which gives a lead as to the distal cause.
Hi, my name's Stephen. I'm a neurology registrar at the Lyell McEwin Hospital in the Northern Adelaide Local Health Network. And today I've got with me Dr. Rudy Go. Dr. Go is a neurology consultant with interest in clinical research and vascular neurology. He's currently conducting a PhD through the University of Adelaide and is the principal investigator on a number of prospective stroke clinical trials. And he's here with us today to discuss a case. Thanks for joining us, Rudy.
Thanks for having me.
So today we'll be discussing a sad case of a young man who presented with a neurological syndrome and unfortunately did not have a good outcome. It's a case that I think it's very important that we all learn from and has several important teaching points, both for neurologists and generalists. So to start off with, we have a case with a 27-year-old male who's presented to hospital after he awoke with a left arm and left leg weakness. His initial examination showed that he was afebrile and in sinus rhythm with a moderate left facial droop, hemihypoesthesia, and mild left-sided neglect. He was systemically well with no significant past medical history. So, Rudy, could you please discuss your approach to a code stroke, as this is, in the setting of waking up with symptoms?
So in the setting of waking up with symptoms, we know that potentially through the wake-up trial, that 9 hours from the mid-time between their last known well time to the time that they wake up. So for example, if they went to bed at 3 a.m. and then they woke up at 10 a.m., so the middle of that would be about 6:30 a.m. So it'll be 9 hours after 6:30 a.m. So your time that you can actually thrombolize the patient does increase to that time, provided that there is a DWI to T2 mismatch on the MRI. So these are sequences on the MRI that can be done acutely in tertiary centers only. Outside of this setting, there's specific situations which allow you to thrombolize the patients. For example, that if someone is in a really rural area that would preclude them from accessing thrombectomy services urgently, excluding those rare cases, usually patients would be precluded from thrombolysis outside of the 4.5-hour window. That's still the state of how things are at the moment, and more trials are looking at extended window thrombolysis as well as extended window thrombectomy, which is currently at 24 hours.
Thanks, Rudy. So just to recap, so when someone wakes up and has a code stroke, they're still a potentially interventional candidate. So time is still brain, and key pieces of information is when they went to bed and when they woke up with symptoms. And urgent access to neuroimaging is critical, in particular MRI where feasible, looking for a DWI, a T2 mismatch.
Absolutely, yes. And basically in the same way, it's important to ensure that more patients have access to MRIs as soon as possible.
So in this case, we've got a multimodal CT scan of the brain, which has demonstrated a proximal right MCA or middle cerebral artery M2 occlusion with a moderately sized perfusion lesion. In this instance, he was treated with aspirin and clopidogrel rather than endovascular thrombectomy or thrombolysis. Could you talk to us about the evidence at the moment around when endovascular thrombectomy and thrombolysis are indicated for patients with a large vessel occlusion and when it's not?
Yeah. So I'll start off with thrombolysis. I think thrombolysis in the current state of evidence, we know from all the trial data so far that anyone with a NIS less than 5 is still an area that is still being studied at the moment. There are multiple trials, including the Tempo 2 trial that we're running at the Royal Adelaide Hospital, that is essentially looking at whether we should be thrombolizing patients with minor stroke, as defined by NIS less than 5. With an NIHSS score or NIS score more than 5, these patients with significant deficits should all be thrombolized as long as they meet the time criteria of within 4.5 hours, or with extended window thrombolysis up to 9 hours with CT perfusion imaging in selected cases. Now, in regards to thrombectomy, patients with large vessel occlusions are now facing individualized decision-making processes at the moment, even though the trial data, again, it's not conclusive in providing thrombectomy in patients with large vessel occlusions with a low NIS of less than 5. However, if someone has, for example, a poorly predictive hypoperfusion intensity ratio, which can predict the penumbra in a patient, or what can be salvageable in a patient at that point in time, as reflected in an MRI in 24 hours, if that shows that the person is going to lose a lot of brain tissue at that point, then there might be a good case to go in and perform a thrombectomy on that patient, even though they have only minimal deficits.
Thanks, Rudy. That's very interesting. So there's some ongoing uncertainty and ongoing research in this area. It's important to support. So in this case, we've got our young man and he's now been admitted. So it's on day 2 after his symptom onset. And whilst an inpatient, he's developed a junctional bradycardia with absent atrial contraction. Now, on review of his admission CT, it's considered that the inferior aspect of his CT angiograms actually demonstrate a mediastinal mass. Now, in this context, he's got a new bradycardia, he's got a mediastinal mass. There's significant consideration for a malignancy-associated cardioembolic stroke as the etiology of his presentation. Now, we're acknowledging that this is an evolving case and he hasn't had a complete workup at this stage, but normally, what are some of the features that make you think about malignancy as a cause for stroke, and how would you work up someone where you're considering malignancy as a cause of ischemic stroke?
Yeah, that's a good question. So starting off with the history itself, it's important to ask questions around constitutional symptoms. So whether someone's lost weight, they lost their appetite, they had fever, or perhaps they're having night sweats where they drench the bed, things like that, to give you a rough clue whether they could have an underlying paraneoplastic phenomenon that's occurring at the same time as their stroke. And otherwise, in terms of other malignancies, asking a history of cancer or whether that could have recurred is really important, just going back to the history and the thorough physical examination, because it's very easy to take a shortcut in thinking that anyone with a multi-territory stroke is likely to have a cardioembolic stroke, but we have to acknowledge that there are also other potential causes of stroke, such as infective endocarditis or merantic endocarditis or malignancy-induced endocarditis that can lead to strokes as well. So it's important to perform a full systematic review and also with a thorough examination of the patient, not just looking at the neurological system, but also examining the cardiac system, looking for murmurs, looking for systemic symptoms such as fever. And from an imaging point of view, as we discussed, looking for any multi-territory involvement, so to see whether an embolus has traveled through multiple vessels, and that would suggest a very proximal cause of stroke, or one of which could be due to malignancy-induced hypercoagulability and merantic endocarditis.
All right, thanks. So when we're considering alternative or unusual causes of ischemic stroke, malignancy is a possibility, and it always comes back to our fundamentals for the trainee. So a history, physical examination, then investigations, and imaging does have a role. So there's features on the brain scan itself, like the 3 territory sign, which might point someone towards malignancy as a cause. But ultimately, we need to consider other etiologies as well. And a malignancy workup often will start with something like a CT chest, abdomen, pelvis, which is what occurred here. Prior to that, though, the patient was changed from aspirin and clopidogrel to apixaban, 5 milligrams twice a day, due to the high pretest probability of a cardioembolic malignancy-associated source. So after that medication change, they proceeded to the CT chest, abdomen, and pelvis, which demonstrated a number of significant abnormalities. So there was a large superior mediastinal mass that was causing superior vena cava obstruction. Then there was also a left anterior thigh superficial fascial lesion, which is fairly large, 70 millimeters by 15 millimeters, without inguinal or subdiaphragmatic lymphadenopathy. There was also multiple subtle sclerotic metastatic appearing lesions throughout the axial skeleton and sternum on this initial scan. Subsequently, the patient proceeded to have a transthoracic echocardiogram to further elucidate the nature of the presumed cardioembolic source. And this, again, demonstrated multiple abnormalities. So there's a distorted aortic root with a mass in the interatrial septum towards the aortic root, with likely extension along the roof of the left atrium. They had a normal left ventricular ejection fraction, and no other real significant abnormalities aside from the one glaring significant abnormality. So this is a challenging case already. There's multiple abnormalities that are going to require careful interpretation. This does raise the differential diagnosis of intracardiac mass, which is a fairly specialized area. And I think it's probably one where you're going to seek help from your colleagues more often than not, looking for the opinion of a cardiologist or cardiothoracic surgeon. And I think that'd be a really interesting topic for future podcasts as well. In this instance, the patient unfortunately proceeded to deteriorate. So on day 3 of their admission, they developed a progressive left hemiparesis and became obtunded and had pupillary abnormalities with pupillary enlargement and a loss of reactivity. This is clearly a deeply concerning scenario. For the trainees, Rudy, could you talk through your approach in this setting where someone's been admitted with a stroke and subsequently deteriorated with these signs?
So when you're working on the ward and you have an acutely deteriorating patient, it is important to quickly perform a thorough neurological examination, but initially performing the examination succinctly with the NIS score, and also determining whether that's actually changed from the initial NIS score itself to give us an objective measure. And also it'd be important to know if there are any changes within the NIS score, what has changed and what are the new deficits and what is old. It's very important to determine what is old and what is new in a neurological case, especially as it could herald in a patient with thrombolysis, for example, a repeat stroke, which could be amenable even if a patient's been thrombolyzed to clot retrieval. We know that patients who have received thrombolysis who deteriorate are more likely to have a recurrent stroke, in fact, much more likely, rather than symptomatic intracranial hemorrhage. Therefore, it's really important that multimodal CT perfusion imaging, ideally via a closed stroke protocol, is initiated immediately upon neurological deterioration. Otherwise, especially in this case where there's a young man with a middle cerebral artery infarction, potentially with a large middle cerebral artery infarction, especially in patients below 60 years of age, it is important to think about decompressive hemicraniectomy, as these patients might have a significant mortality benefit. Even though there might be not much morbidity benefit at this stage, it is very important to perform the procedure before any deterioration happens, because once any deterioration has happened, it is likely that you have missed the boat. So to summarize, it is important to get a very thorough examination, knowing what is old and what is new in terms of the deficits, and also to proceed to urgent imaging as soon as possible. Call up your friendly radiologist and say, I need a scan right now. Let's get it done, as time is brain.
Thanks, Rudy. So to recap for the trainees, so the neurologically deteriorating patient after a stroke is a specific presentation with a specific set of differentials, which includes symptomatic intracranial hemorrhage following thrombolysis, but is not limited to that, and also includes the possibility of repeat ischemic infarction, which are clearly managed differently. They need to perform a timely evaluation, looking for new changes, and facilitate urgent head imaging, which will be in part guided by their centre and local protocols. Would that be fair to say?
Yep, absolutely.
So in this instance, a repeat non-contrast CT was sought urgently, and it unfortunately demonstrated a large right parietal intraparenchymal hemorrhage with intraventricular shift. There was obstructive hydrocephalus and uncal herniation along with parafalcine herniation. He did proceed to an emergency right hemicraniectomy. In this time over the following day, the thigh lesion was biopsied, and the patient was treated empirically for an infection with meropenem and voriconazole. And ultimately, the biopsy cultures grew an unexpected result with Aspergillus flavus identified. So, Rudy, could you please talk to us about what are the normal indicators that you would see clinically to suggest infection as a cause of ischemic stroke? And then what does that mean for the risk of hemorrhagic transformation like the patient has unfortunately suffered in this instance?
Yeah, so when you have fever, when you have severe headache, things like if a patient who is immunocompromised, for example, and if someone's using intravenous drugs or whether they have any indwelling long-term venous catheters or sort of imaging findings of having a mediastinal mass in this case, for example, or leptomeningeal enhancement seen in the brain. So those are things that would make you suspect that there might be invasive infection of some sort, which in this case, unfortunately, only a few of these clinical features were present. So these are the things I would generally look for.
That's really helpful. And it is important to note that sometimes it can be occult. And that's why examination and re-examination is important. And it does have implications for the risk of hemorrhagic transformation. Could you talk to those risks briefly?
Yeah. So we know that in patients with an ischemic stroke, the risk for hemorrhagic transformation would include being on blood thinners. And some would argue that some anticoagulants make you at higher risk of hemorrhagic transformation as opposed to antiplatelet therapy at the time of initial stroke, especially with anticoagulation, especially if whether they've had thrombolysis, would increase the risk of hemorrhagic transformation as well. In this case, where there is a patient with an infective cause of endocarditis and leading to a stroke, essentially, if they have a mycotic aneurysm, that would significantly increase the risk of having hemorrhagic transformation from that stroke itself. If they're on the CT scan or a digital subtraction angiography showing an early venous drainage sign, there will be an indicator of potential early hemorrhagic transformation as well. And it is important to keep this in mind, especially when thinking about surgery in infective endocarditis. Many tertiary centers and metropolitan centers have started infective endocarditis multidisciplinary meetings with collaborative efforts being put in by the infectious diseases neurologists as well as the cardiothoracic teams to try and optimize outcomes for patients with endocarditis potentially requiring surgery in the acute setting after acute ischemic stroke.
All right, thanks. So just to summarize, so when there's an ischemic stroke in the setting of infection, in particular infective endocarditis, there can be an increased risk of hemorrhagic transformation, in particular if there's mycotic aneurysms. And these patients often require subspecialty management and multidisciplinary involvement. That'd be fair to say?
Yep.
Now, in terms of our case, unfortunately, the patient on day 6 of their admission had no neurological recovery, and he met the clinical criteria for brain death. This is a very sad outcome in a young patient. His autopsy showed disseminated A flavus complex infection involving multiple territories or multiple regions, including the thigh, the mediastinum, and the brain itself. So this infection was angioinvasive and had infiltrated the brain parenchyma. And this is presumably the etiology of the hemorrhagic transformation. This case has demonstrated the potential severity of ischemic stroke with the death of a young, otherwise well patient, and has also highlighted the importance of considering unusual or atypical etiologies of ischemic stroke beyond the conventional arteriolosclerosis or atrial fibrillation that we deal with every day. What were your take-home points from this case, Rudy?
So in any case of ischemic stroke, especially in a young patient, it is important to think broadly and not just to default to calling it a cardioembolic stroke just because it affects multiple territories, and to look at the patient and perform a good systematic review, looking at the entire body, including the skin, not forgetting the dermatological system as one of the largest organs in the body, especially looking at the thigh itself was a good clue for what was going on in this patient. And It's also important to involve our colleagues as well, to collaborate with other specialties such as the cardiologists to try and provide the best care and outcome for our patients, especially when they have complicated clinical history and presentation, so that we can put all our minds together to come up with a holistic plan for the patient that takes into account all of the abnormal findings that we have.
Well, thank you for that. So I really appreciate your time joining us on the podcast, Rudy. I think I've learned a lot from this case. We're grateful to the patient's family for having shared their story so that we can all learn and we can all provide better care in future. It's always very sad when the young person dies from any cause, but ischemic stroke particularly does strike quickly. And we're passionate about it, and I think that we've learned several things from this case and also highlight a few areas of ongoing research where we can continue to develop medical knowledge in this field and work towards treating ischemic strokes in future. So thanks again, Rudy.
Thanks, Stephen.
And otherwise, we look forward to the next discussion. Bye for now.
That was Associate Professor Stephen Bacchi with another fascinating pomegranate case report. The actual paper was published in Case Reports in Neurology, February 2024. The full text is freely available under the title Disseminated Aspergillosis with Mediastinal Invasion Causing Fatal Stroke in an Immunocompetent Young Man. The first author was Dr. Robert Yarham and the senior author Professor Timothy Kleinig, who conduct their research through the University of Adelaide along with Dr. Rudy Go. To find more case reports, go to racp.edu.au/podcast and then scroll through the episode archive. It's a bit easier to search for episodes from a pod browser like Spotify, Apple Podcasts or Castbox, but first you need to subscribe by typing in Pomegranate Health, and you can now even find us at the RACP YouTube channel. As well as the case report format, there are the IMJ On Air episodes, recorded with authors of articles published in the Internal Medicine Journal. The episodes prefaced with Journal Club adopt a similar format, but showcase impactful research published in other journals by members of the RACP. In all of the above formats, the interview will be led by an RACP physician, whereas the episodes prefaced with the EP number are those that I've developed myself. They will cover a range of cultural and professional topics, not just clinical ones. And you'll occasionally see episodes tagged Guest Lecture, where I share with you particularly engaging seminars that I've come across. There truly is something for everyone, and don't forget the College Learning series located at elearning.racp.edu.au. These lectures are written around the basic training curriculum, and there are 19 lectures each on neurology and infectious diseases. This podcast was recorded on the coastal lands of the Gardner people in Adelaide and the Gadigal clans of Sydney Harbour. I pay respect to the elders past, present, and in training. I'm McEwin. Thanks for listening.